The broadcast is now starting. All attendees are in listen-only mode.
Hello, everybody, and welcome today. My name is Sasha Spencer. I'm the Director of Education and Intersectional Collaboration at Anchor. We're going to give everybody just another minute or two before we get started, and I will then have the joyous opportunity to introduce you to some of Anchor's most important partners here at IntellectAbility. So we'll just give everybody another minute or two. Wonderful. It seems like we've reached our good number for us to get started today. So again, my name is Sasha Spencer, and I'm the Director of Education and Intersectional Collaboration at Anchor. And today we're joined by some of our key partners, the wonderful people from IntellectAbility. So before we get to their bios, want to make sure that everybody is in the right place today. Today's webinar is about leveraging HCBS American Rescue Plan, or ARPA's Act, to funds to address healthcare disparities for people with IDD. So without further ado, making sure that you're in the right place, and if you're not, we hope you continue to join us today. The first person that we're going to introduce is Dr. Craig Escudé. Dr. Escudé is a board-certified fellow of the American Academy of Family Physicians and the American Academy of Developmental Medicine, and is the president of IntellectAbility. He has more than 20 years of clinical experience providing medical care for people with IDD and complex medical and mental health conditions, serving as a medical director of Hudspeth Regional Center in Mississippi for most of that time. While there, he founded Detect, the developmental evaluation, training, and educational consultative team of Mississippi. He is the author of Clinical Pearls in IDD Health and the developer of the Curriculum in IDD Healthcare, an e-learning course used to train clinicians on the fundamentals of healthcare for people with IDD. Joining him today is Lorene Reagan. The RN in MS and she has over 35 years of experience providing support for people with IDD, their families, and their caregivers. Prior to joining IntellectAbility as the Director of Public Relations, Ms. Reagan served as the Bureau Chief for the IDD services and as the Senior Medicaid Policy Administrator with the New Hampshire Department of Health and Human Services, was the manager of a care management for a Boston-based Medicaid managed care organization, and a principal with Mercer Government Human Services Consulting, providing clinical and policy supports to state Medicaid care programs all across the nation. I'm having trouble calling her Ms. Reagan because I know her the most as Lorene, so that's what I'm going with as our partners. We work closely together. So Lorene is passionate about educating and informing those responsible for maintaining and restoring wealth, wholeness, and a good quality of life for the people with IDD. So like we said at Anchor, we're very proud partners with IntellectAbility. Craig and Lorene have been with us for some of the key moments that we are trying to build out for community knowledge and education. And today, we could not be more proud to welcome them in this incredible webinar. So we're so glad that you're able to join us, and we'll turn it over to them to do the rest of today's presentation. Thank you so much.
Thank you so much, Sasha, for that very, very warm introduction. And we are very happy to be partners with Anchor as well, and help work together to improve health and wellness in the lives of people with intellectual and developmental disabilities. Thank you all for joining us today. And I'm going to jump right in and start off by talking about why do we need to even think about improving health equity and health and wellness for people with intellectual and developmental disabilities. And one of the key concepts I want to touch on first is the difference between health equality and health equity. So equality, really means everybody has access to an equal something. It might be a scale, for instance. Everybody has access to a scale. But if not everybody can utilize that scale, then there is not an equitable way to get the weight for everyone. For instance, if the scale cannot accommodate people who might be in a wheelchair, then they might have equal access to the scale, but they don't have equitable access to being able to get an accurate weight. This holds true as well for healthcare providers. Everyone might have access, say, to a primary healthcare provider, but we know that all healthcare providers don't necessarily have the training, the background, the education and understanding as I did when I first started in this field. So if people with intellectual and developmental disabilities maybe have access to primary health care, but they don't have access to a primary health care provider who knows how to provide health care to them and understands the differences, then they may not have health equity or an equitable care. So health equity is achieved when no person is disadvantaged because of a social position, disability, or other circumstance. We know that there are health disparities in people with intellectual and developmental disabilities. These are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. The National Council on Disability earlier this year released a document called the Health Equity Framework for People with Disabilities. It's in our references at the end, and I think it's great for you to take a look at it if you're not familiar with it. And it really talks about that people with physical and intellectual or developmental disabilities are at significant risk for health disparities. Other things that contribute to health disparities are disability bias. We know that there are negative perceptions and inaccurate assumptions that are often made about the quality of life of people with intellectual and or developmental disabilities. This bias is often unconscious. People don't always, are not outwardly biased against people with disabilities, but sometimes it does certainly weave its way into the fabric of supports and services and care and health care for people with IDD. Healthcare providers are certainly not exempt from these deficit-based perspectives, and they have a high level of influence in healthcare decisions. And this can lead to healthcare providers believing maybe, for instance, that preventive care and other types of care are not necessary. You may have had the experience where someone was told, well, they don't really need to be screened for colon cancer or for have a dental screening or whatever it is. And these things are examples of maybe having a bias and not recognizing the importance of some of the supports and services that are needed. I really want to take this moment to talk about the medical model. This is something that or this particular misconception that I'm going to touch on is something that I've really become more aware of. We used to think about, clinicians used to think about the medical model of supports and services for people with IDD, where we saw disability as a defect that needed to be corrected by some sort of medical intervention. Well, that is old. That is outdated. That's not how we see things now. We've moved more towards the social model, which really promotes accessible environments for all and helps to ensure that people, regardless of their differing abilities, have health equity and equitable access. And we're not trying to fix a deficit. We're trying to create an environment, a universal environment where people can have equal opportunities to experience life and experience good health. What I hear sometimes when we talk about health and health education and health care is that, oh, that's the medical model and we don't want to go there. Well, I would say that really this is in direct opposition to the medical model when we talk about supporting and providing equitable health care so that people with intellectual and developmental disabilities have access to the same level of health care that people without disabilities do. Competent medical providers, facilities that allow them to be able to utilize, various pieces of equipment for, say, a weight or for a mammogram or so on and so forth. So it really is in opposition to the medical model. Another thing I want to touch on is something called diagnostic overshadowing. The Joint Commission, which I'm sure many of you are familiar with, it's a large accrediting body, but I think the largest for hospitals and health systems. in the country, and they put out a Sentinel event alert in June of this year talking about diagnostic overshadowing. And what that means is where we maybe attribute a person's behavior, for instance, especially in the IDD world, where we might see a person who has a new behavior, and where the clinician may attribute that behavior to the fact that the person has a disability, and says, "Oh, well, they're hitting their head, for instance, because they have a disability." So what that really leads to is really an incomplete assessment, and the differential diagnosis of what else might be causing these behaviors are really not considered. Sometimes this even leads to a person being put on a psychotropic medication to treat these behaviors, never really fully assessing or recognizing that this could be stemming from an underlying medical condition. So that the diagnosis is overshadowed by the person's other conditions. In this case, it would be an intellectual disability. And we can address these things through healthcare provider and supporter education. There are gaps in preventive care. I'm not going to spend much time on this. We know that people with intellectual and developmental disabilities have lower rates of preventive screenings for cancer and for dental screenings, and higher rates of chronic conditions as well. And these things existed even before the pandemic. The pandemic certainly didn't help, as we know that many people missed appointments for routine health care during that time. But Medicaid beneficiaries, there have been gaps in this area for a long time. 1 in 4 Medicaid beneficiaries, only 1 in 4 have had a colonoscopy if it was appropriate for them and their age in the past 5 years. And less than half who should have received cervical cancer screening have actually received it. And these differences can certainly be amplified by race and ethnicity as well. I want to talk about the impact of clinician education on health disparities. And you're going to see how all of these things that we're talking about are going to lead to some things that we can possibly help with. But there was a study done earlier out of Harvard that showed that 82% of physicians surveyed reported that people with significant disabilities have a worse quality of life. And if we start off with the understanding that this person's quality of life is less than others, that can certainly affect the way we say recommend preventive screening or certain measures to improve a person's health. In that same study, only 41% of physicians were very confident about their ability to provide the same quality of care to patients with a disability as to those without a disability. So only 41% were confident. 57%, only 57% strongly agreed that they welcomed patients with a disability into their practice. So again, this goes to inequities in health for people with intellectual and developmental disabilities. Talking about social determinants of health, we're hearing more and more about this. These are conditions in the environment where people are born, where they live, where they work, play, worship, all of these things that can affect a range of health and functioning and quality of life outcomes and risks. People with IDD are more likely to have unmet social needs across all of these domains. And it's so important that we consider these things because it's estimated that 80% of health outcomes are related to a person's physical environment, social determinants of health, and health-related behaviors. That's a significant percentage. Now, we look at people who have an impact on the lives of people with intellectual and developmental disabilities. Direct support professionals have a significant impact and can greatly affect and positively affect health disparities. We know that direct support professionals play a critical role in supporting people's day-to-day health-related and functional needs. And they are often the front line. They are the front line for recognizing health destabilization, health risks, and also often the front line for helping a person access healthcare services. They often accompany people with intellectual and developmental disabilities who they're supporting to healthcare visits. So I think this just speaks to the need for training and education around health-related issues and the impact that can have to improve or improve health disparities or reduce health disparities for people with IDD. The workforce crisis, we know, has certainly gotten worse with the pandemic, and these high vacancy levels and high turnover rates can negatively impact efforts to promote optimal health. And so the opportunity or the availability of education about support needs is paramount. And sometimes when, because of the, excuse me, because of the need to get people out there working, they may be working with people and providing supports and services before they actually receive all of their training. So having the availability to have training, say that it's basically on demand or e-learning type training, can be helpful as well. Excuse me. All right, so misperceptions about the quality of life and unconscious bias we know can contribute to deadly health disparities in people with IDD. And we saw this a lot in terms of, this was really amplified by COVID. We saw that people with IDD had the highest, having an intellectual disability was associated with being the highest independent risk factor for contracting COVID-19, and that it was secondary only to age for COVID-19 related deaths. One study showed that people with IDD were 6 times more likely to die from COVID than people without intellectual and developmental disabilities. And a very recently released study looking at death certificates and the cause of death for people with IDD, the top cause of death was COVID-19 in 2020. So it's certainly amplified, the health disparities and the health risks. So I'm going to turn it over to Lorene now to talk about some of the things that are happening with the ARPA plan and some of the wonderful opportunities that the ARPA plan is presenting to help providers and states and agencies to address health issues and health disparities.
Great, thanks so much, Craig. We're not going to spend a lot of time on this, but we thought it would be helpful to just orient people to the American Rescue Plan Act of 2021, or ARPA, depending on how you refer to it within your state. But really, the funds made available through ARPA for home and community-based services really, I think, are a game changer for us. And for those of us who have been in the field for a long time, I think one of the things that we struggled with the most was really trying to ensure that we were serving as many people as possible, and also making sure that we were able to provide support for training and support for capacity building and support for increased wages for direct support staff. And those things really weren't always possible for us. ARPA, though, has brought us to a place where we have some opportunities to address some of the sort of non-direct service areas that are really critical. And we're going to talk a little bit about those. I mean, $25 billion in planned spending across states for HCBS ARPA funds is just a huge, huge amount of money. We're going to look at, first, we're going to look at information that was in states' spending plans, some examples, and you can see from the slides that this comes right from CMS. And we'll start with looking at information about what states proposed, which is what was in state initial plans, and then we'll talk about what we're seeing from states today and most recently around how they are actually implementing those plans. So thinking about state initiatives, the first area, there's 5 main areas where states have proposed initiatives, and the first one is around expanding beneficiary services. And ARPA funds, availability of these funds have given states some real opportunities to take a look at existing sort of authorities, the different existing waiver types, and expanding those waiver types, maybe looking at things like offering a personal care benefit under a 1915I waiver, and looking at and really developing out some opportunities for allowing spouses and parents, for example, to become support workers for their family members or paid providers. And then you can also see, and you will also see, a number of initiatives that are focused on supporting children under the age of 21. So people with intellectual and developmental disabilities before they hit that, in many cases, over under 21 split for services. So you can see there's some initiatives there. We, again, look in this area, CMS estimated about $10.3 billion in total spending in this area. Strengthening the provider workforce is a second category, and this is really, I think we all recognize this is really a critical area. So really looking at, first and foremost, many states came right out of the gate with DSP one-time payments to look at things like recruitment and retention, then also looking at education and training for direct support professionals. And almost $5 billion in total spending was proposed for rate increases and adjustments around things like retention payments and one-time bonuses, but then also looking at some things like loan forgiveness, incentives for completing trainings, and then really looking at, in some cases, ongoing hourly wage increases and benefit packages. So lots of work when we look at the strengthening the provider workforce around compensation, and then also around training. Big area and lots of need when we think about enhancing the use of technology and telehealth. And I think we're all aware that, you know, many states and even provider IT systems are either out of date or maybe not working in the ways that we'd like. And looking at things like interoperability, ways that we can connect systems, not only within between a state developmental disabilities agency and providers, but also looking to expand beyond that to develop some interoperability between our systems and hospital systems to look at things like admission, discharge, and transfer alerts, that kind of thing, but also the huge expansion of telehealth. And one of our key partners, anchor partners, is Station MD. And we're actually working with Station MD on looking at interoperability between our health risk screening tool and the Station MD platform, so that when states have both tools in place, Station MD physicians and clinicians are able to look at health risk related information for people that are supported when they receive an incoming call about looking for telehealth support. So there's also, you can see some other examples here of some pilot programs that are looking at remote patient monitoring, expanding the use of some IT systems for critical incident management and sentinel event reporting, and really looking at ways that an electronic health record can be pulled into place, which is something that, again, in most states we don't tend to have for people with IDD. Lots of work proposed around improving quality and looking at things like outcome-based payment initiatives, looking at the development of quality measures, either updating existing quality measures or developing new quality measures, and, you know, really looking at some ways of incentivizing frontline worker education and incentive payments and achievement of certain measures so that we can improve the quality of services provided to the people we're supporting. And lastly, really important area, and Dr. Escudé mentioned this as one of the areas that contribute significantly to health disparities for people with intellectual and developmental disabilities, and that's the area of social determinants of health, and really looking at some state proposals to improve things like employment, to address areas such as housing, access to healthy food and those types of things, and really looking to see how it is that we can address social determinants of health for the people we're supporting and develop infrastructure in this area so that as we move forward after ARPA ends or winds down, making sure that we've really paid close attention to improving and acting on and trying to meet people's social determinants of health. So we know that an extension was granted for states. This was not a surprise to most. There's lots of work that goes into implementing this kind of huge initiative. And so I think most people were pretty happy to see that CMS provided an additional year through March 31st of 2025 for ARPA HCBS funds to be expended. So that was terrific news. And what we're going to talk about next is really just to provide a little bit of a snapshot into what we're seeing in terms of state approaches to ARPA-funded initiatives. We've talked about some of these as some of the top 5, but again, looking at funding for new or innovative approaches, that's another area where, we're often so, unable to really look at newer innovative things because they cost money. So we've seen some of those, and we'll talk about those. A lot of states are offering grants to providers for specific initiatives within a specific ARPA funding category. So the state may have identified an area that they'd really like providers to focus on and have issued grant opportunities for those specific initiatives. There's also been opportunity for providers to identify initiatives that they believe are important and funding being made available from states for those initiatives that are identified by providers. Most of what we're seeing are one-time or time-limited initiatives, and that's really likely due to the nature of these funds. The additional FMAP or federal matching that's available under the ARPA HCBS funds of 10% is only available for a short period of time. So many states have really focused mostly on one-time time-limited initiatives, but some states have gone out on a limb and decided to utilize that increased FMAP and allowed for some ongoing and open-ended initiatives. And then what's really exciting, I think, to see is funding that's been made available to support new or difficult to reach or serve populations. And when we look at a couple of the state examples that we've seen where grants have been offered in the past year, we'll see some examples of this. But before we get there, one of the things that we really thought a lot about as we were contemplating, how might we be able to reach out to states and providers to support them in implementing ARPA initiatives. What we know is that really states and providers are grappling still with the aftermath of the COVID-19 pandemic and, of course, with the direct support workforce crisis. We know that many are struggling just to maintain sufficient staffing resources to manage day-to-day operations. That's not something that's new, particularly at the state level. And that there are administrative burdens related to managing ARPA funds, although CMS has really done a nice job and did release a state Medicaid director's letter, talking about some ways that they'd like to really reduce that administrative burden, but it still exists. There's still a need for accountability for funds that are expended in this area. And really thinking about and recognizing that many states were, put together their ARPA spending plans, and they were really all considered proposals because, again, with everything else going on, states took a lot of stakeholder feedback. We saw some terrific work in that area, but in some cases were, provided to CMS some pretty broad proposals, and that over time, those proposals would be made more specific, and that also over time it's possible that we'll see some of those plans amended based on current realities or emerging needs, and even as we move towards 2025, the ability of the state to expend the funds as planned. So really some of the work that we hope that we've been able to help with is really supporting states and providers to identify, apply for, and in some cases really helping with completing grant applications for in areas where they wanted to be able to address needs that they had in front of them, but really helping states and providers to make sure that if they needed our support in requesting or responding to grant applications, that we would be able to help them with that. So next, we'd like to really talk about what we're seeing in terms of moving towards implementation and some of the grant opportunities that are available. And you can see here that Pennsylvania had issued some proposals asking for projects for providers who are interested in implementing projects to address social determinants of health, to look at access to competitive and integrated employment, purchase of remote support technology to support that documentation of the services that are occurring in the home for waiver participants, and looking at documenting conditions as well as related care needs, and looking at the purchase of technology and software for either electronic health records or risk management functions. We also saw and found information for grant opportunities in Illinois around looking at really focusing on IT and meaningful use and interoperability for things like electronic health record systems. Looking to provide grants for support around compliance with the HCBS settings rule or with electronic visit verification. And then expanding provider capacity to serve HCBS or HCBS waiver or habilitation participants, because again, we've seen a shrinking in the provider, in the availability of providers as well as direct support workforce. And then really looking at some areas of training and scholarships for education in training in nursing, behavioral health, other healthcare fields for people who are currently working in the field to provide career ladder opportunities. And lastly, we'll take a quick look at North Dakota and some grant opportunities that were available to support new providers who would like to enroll to provide HCBS services, supporting current providers who are looking to expand into new geographic areas where there's a need for HCBS services, and then really looking at and recognizing that many providers might need support around helping them to assess and improve their business operations. And lastly, looking, of course, at things like staff training, professional development, recruitment and retention, and even allowing for some funding for background checks, which can become costly. And then this one was of real interest to me. I thought, well, this is really, I think, a place where you can look at, think about in the past, have we ever had an opportunity really where we could provide, for supporting operating costs for maybe a new provider coming into the market. So some really, really great innovative things that we've been able to find in terms of how states are moving forward with implementation.
Thank you, Lorene. I am going to talk now about some things specifically related to IntellectAbility, some products and services and tools that we have, and in relation to their utilization with ARPA funds that we're working with either states or other agencies or some other opportunities that exist as well. One of the things that we talked about is the importance and the value of training. Having online web-based training can certainly fit into the ARPA fund abilities, I guess, or the ARPA fund allowances. And what we saw even before the ARPA funds were available is that some states, especially during COVID, who needed to continue training that was in-person training, we were able to assist them in transitioning in-person training or paper-based training to e-learn type training. So that's one opportunity that certainly exists. We do a lot of custom development for clients in terms of e-learning training or just various types of training and education for staff and for other supporters in terms of enhancing current e-learn training offerings as well. Another area, and we'll touch a little bit more about this as well, but implementing other tools that are available, such as the electronic person-centered description. We have an electronic person-centered description where information through the person-centered thinking and planning process can be entered that can provide a concise record of essential information in an electronic format that can be easily shared amongst supporters. We've also been asked to help or to expand learning management system capabilities to help organizations put all of their trainings into, say, one learning management system. So enhancing the ability to do that for organizations is something that we are able to do and have done as well too. I mentioned person-centered thinking, and I want to call your attention to the right side of this slide just to help drive home why person-centered thinking is so valuable. It's more than just because it's required by the final rule. If you look at the slide on the right, this is information from CQL. If they're talking about the number of injuries for people with intellectual and developmental disabilities, and if you look at the center circle there, it was 61% lower number of injuries when agencies implemented ongoing staff development. And when you look to the right circle at the bottom there, 53% lower when supports and services enhanced dignity and respect. And person-centered thinking training and person-centered training is all about respecting and enhancing that dignity and respect in people with intellectual and developmental disabilities, helping them to balance what is important for them for safety and health and wellness with also what is important to them, and making sure that they have choice and control and options to live the lives that they would like to live. So one of our divisions at IntellectAbility is our person-centered services division. We provide online training, in-person training, and we also have e-learn training specifically geared to teach concepts and person-centered thinking concepts. We can also help and have helped agencies and states build capacity to do their own training by providing trainer credentialing so that you have trainers in your own organizations to continue that process. And also working there are opportunities in inclusive post-secondary education as well in terms of helping them support people with IDD in a very person-centered approach to help improve the success of their post-secondary and college education. Other things include health risk management and really looking at health issues. And so we're talking about, in the first part of the talk, we talked about so many of the health inequities and so many of the issues, and how training and especially training of frontline staff and direct support staff and nurses and case managers to recognize health risks can reduce health disparities. And so a great way to provide training is through electronic learning. It makes that training available from day one, so they can help ensure that people get access to the training that they need right away. And our second division, our academy division, is focused on health-related training for all levels of supporters, including direct support professionals, nurses, case managers. One of the biggest courses, the most widely used courses that we have is on the Fatal 5, which teaches different supporters how to recognize some of the most common preventable causes of death and illness in people with intellectual and developmental disabilities, talking about things like aspiration, dehydration, seizures, constipation, bowel obstruction, gastroesophageal reflux disease, things like that. We also have courses on choking that were developed specifically to address people with intellectual and developmental disabilities, talking about prevention, but also about how to treat someone who might be in a wheelchair, who has different body shape of their body if they're choking, and how to help relieve that. And certainly the web-based, having a web-based health risk screening opportunity, having an ability to screen for health risks that are often missed, and having a tool that can do that and that can provide information to help mitigate those risks is something else that certainly fits in to the opportunity to use this new funding available to enhance electronic systems and other services and training for people with intellectual and developmental disabilities. Lorene mentioned interoperability, and this is a big thing. We have a lot of electronic systems that have come on in the past years, and some of us are using a number of different ones, and we'd like to have them work together better. So we have opportunities and have done things to develop single sign-on. For those of you who are using, for instance, the health risk screening tool, there are opportunities to develop ways to make it easier to access and to interface with others. Lorene also mentioned an exciting project with Station MD, which is a provider of IDD-specific telehealth, telemedicine services and supports, to where they will have health risk information data from our health risk screening tool available in real time as these clinicians are doing a telehealth visit. they will be able to see the person's risk profile, which will help them make clinical decisions and make important clinical decisions because they will have a specific health risk profile and know what are the specific risks of that person. We're actually doing a webinar later this month on October 27th that is going to address that in much more detail, and we invite you to join us for that one as well. Also, in terms of education on the healthcare provider level, this is something else that we can do and we are doing and can help with, again, to help improve or reduce health inequity, but it's helping clinicians understand the fundamentals of providing healthcare to people with intellectual and developmental disabilities through our e-learning course called the Curriculum in IDD Healthcare. This is a course that can be utilized to provide specific training about IDD healthcare, clinical training for clinicians, and it is approved for continuing medical education credits for physicians and continuing education units for nurses as well. So, in conclusion, we know and certainly believe that the HCBS and ARPA funds really, this is an extraordinary opportunity to enhance supports and services in a number of different ways for people with intellectual and developmental disabilities. And specifically, IntellectAbility can help by developing e-learning training for states and agencies on specific topics or implementing some training that's already developed. We can help enhance interoperability between electronic systems. We can improve access to health risk information through the health risk screening tool, which is extremely valuable information to have to help reduce health disparities. We can provide training to support staff to recognize and act on common preventable health conditions through the Fatal 5 and other courses that we have. And we can help foster IDD healthcare competency among clinicians through the Curriculum in IDD Healthcare e-learn course, and certainly enhance person-centered thinking skill sets to help support people with dignity and respect, which we know can reduce injuries, among other things, in this field. So I would invite you to reach out to us to learn more, to visit our website. We would be happy for you to reach out to either myself or Lorene directly. Our email addresses are there. And I really also want to take the opportunity just to recognize all of you and thank you for all of the support that you provide in this field. It's been a tough 3 years, no doubt. And we are here to help in terms of anything related to health and wellness in people with intellectual and developmental disabilities. So that's all we have time for today. And
Right.
Yes, Lorene?
So we do have a couple of questions, 3 questions in the Q&A, but it's actually all the same question. And the question is really around whether or not the slide deck will be available. And yes, we will send that out to participants after this webinar.
Yes, we will. And we'll also send out the recording to this webinar as well, too. Yeah, and if there are any other questions, please pop them into the window that Lorene found.
We'll give just a moment, and then if there are none, then that's great too. Well, not seeing any additional questions, we thank you all for your attention today and for the time you've taken to join us. And also, again, would like to recognize Anchor for this opportunity. We really appreciate our partnership and also appreciate all the great support that we got.
Absolutely, but before we go, I see someone has their hand raised. So,
wait.
Myra,
Okay.
I have unmuted you if you'd like to ask your question.
Hi, thank you. Yes. So I work for National Disability Institute. I'm a public policy fellow. So we focus on financial well-being and independence for people with disabilities. And I was wondering too if you could speak a little bit to how this may impact ABLE account holders. And if any of these funds are being used to maybe expand ABLE accounts, because I know that each state has their own ABLE account, and the organization that I'm a part of, we sort of have a state-by-state comparison tool, meaning that if you live in New York but you like the Kentucky plan better, you can use Kentucky's ABLE. So I'm just curious about that.
Wow. So Myra, that's a really great question.
Yes.
And it unfortunately, it's sort of beyond what I think we can help you with in this webinar. I'm wondering though if there's any other participant on the webinar today that might be able to comment on or maybe connect with you about ABLE accounts and the impact of receipt of ARPA funds, because that is a very good question, and certainly understanding that you would never want to destabilize your ABLE account in any way, right? Is there anyone else? And maybe you could reach out, and I'm sorry that we can't answer that question. It's just not something that we work with here, but it would be nice if there's someone else who's on that might be able to reach out to you either through the Q&A or the chat. So I'm sorry we can't answer your question.
Thank you, especially given that we're hoping to get ABLE age adjustment passed, so there'll be even more individuals impacted by that as well.
Right, great question. So again, if there's anyone that can maybe reach out to Myra and answer that question, we would really appreciate it.
Yep, just raise your hand on the webinar, and we'll open up the mic. Well, unfortunately, it doesn't look like we have an answer for that question yet. But any other questions? Do we have any other ones that have come up?
It looks like, oh, wait a minute. Did you want to say something else? Could you just unmute Myra again, please, Craig?
Sure. I think, I'm sorry, I'm having to scroll through the list.
I was able to unmute myself.
Oh, you did. Sorry.
I had one last question. Yes, I'm also a physician assistant student. So I was wondering if you had any other resources that I might be able to share with classmates about this, because right now we're just about to start didactic year, so this isn't something that we necessarily talk about, although we do have, basic preventative medicine courses and things like that. But I'd like to be able to pass along resources since I'm the DEI chair.
Absolutely. We have.
Sorry.
That's good. It's a great question.
I mentioned the curriculum in IDD healthcare. It's an e-learning course that's geared to clinicians, and it's currently being used in a medical school and a couple of nurse practitioner schools, nursing schools, and other ways to, other types of settings to train both health professional students as well as practicing clinicians. So if that's something.
Do you also do guest speaking too? Because our program, I know that we have a preset curriculum already. We're the first cohort. I'm actually in a hybrid physician assistant program. So we have a lot of online lectures. We only go to campus a couple times a year. So they also do a lot of guest lectures.
Yeah, we do. I do lots of talks. It's my favorite thing to do when it comes to, teaching others about.
Sorry for asking so many questions.
Oh, no, this is great. We appreciate it very much. But yeah, you can reach out, and we're happy to, set up a talk for you. We can certainly do that.
Great. Thank you so much.
Yes.
All right. I don't see any other questions, Craig. So I think we can close.
Well, again, thank you all for joining us, and we will send this the handout and the information out to you after the webinar. And if you have any questions, please reach out.
Terrific.
Thank you very much.
Thanks, everyone. Bye-bye.
Bye-bye. For some reason.